of communication and family and community engagement. This workshop will be conducted by Dr. Andy Shih. And I will read Dr. Andy Shih's biodata once again, just in case if some missed it. Dr. Andy Shih is Autism Speaks Senior Vice President for Scientific Affairs, and his main task is to develop and implement the organization research program. He also oversees the administration to the organization grant-making process for research. Dr. Shih joined the National Alliance for Autism Research in 2002. Prior to joining NAAR, he had served as an industry consultant and was a member of the faculty at Yeshiva University and New York University Medical Center. He earned his PhD in cellular and molecular biology from New York University Medical Center. Dr. Shih's research background includes published studies in gene identification and characterization, virus-cell interaction, and cell cycle regulation. He was instrumental in the cloning of a family of small GTP cases involved in cell cycle control and nuclear transport, and holds 3 patents on nucleic acid-based diagnostic and therapeutics. And for the topic in this session, which is soft skills in service provision, the importance of communication and family and community engagement, as having a child diagnosed with autism can be confusing and emotionally overwhelming experience for parents and other family members. Autism affects more than the child, often adding pressure on family finance, caregiver employment, relationship, and overall quality of life. The pervasive lack of awareness, crushing stigma, and seeming dizzying array of treatment options further add to the challenges faced by parents and caregivers. Research and strategies for enhancing communication and engaging family members, professionals, stakeholders, and the wider community to better meet the needs of children and their families will be discussed. And now I would like to invite Dr. Andy Shih to conduct the workshop.
Thank you very much. It's a pleasure to be here. And first I want to just say that I'm not an expert on intervention or service provision. But what I'd like to offer you today is my understanding of some of the research being done in terms of how to really enhance the impact and the effectiveness of interventions in the community, with the family, with the individual. And the key, as you may have guessed, is really about communication. I think in the United States, the experience has been, for most family in the United States, and this is the reason why this advocacy group like Autism Speaks exists, interactions with service providers, professionals, hasn't always been a very positive one, and there are many factors involved. And what I'd like to do is to first give you a brief presentation that really lays out some of the thinking on this issue, as well as share with you some of the most recent research in terms of how to really best engage stakeholders, that means family members and the wider community, when you think about designing an intervention program or developing a service provision for individuals and families. So I can't see this very well, but I'll try to lead you through this. So this is really kind of where we are in terms of autism. I think the important thing is that obviously this is DSM-4, based on DSM-4. Okay, let me stand up. Okay. Oops. Okay. So this is DSM-4. You still see social deficits, repetitive behavior, language impairment as a triad for autism spectrum disorders. Obviously, DSM-5 that's changed. But that's not really the point of the slide. The point of the slide is really all the other conditions and co-occurring medical issues that goes with the child on the spectrum. And they could vary from things like sleep deficits and moods and to self-injurious behaviors, seizures, and so on. So it's really a complicated medical picture for individuals with autism. And it's important to keep this in mind. But I think the bottom line is that we know, one thing we do know about autism is that the earlier you can diagnose, identify autism, the earlier you can get the child into appropriate intervention, the better the potential outcome. So this is what the focus is here. Okay, wait a minute. Okay, so in treatment services of individual autism, there's two components. One is medical care and one is behavioral intervention. As I shown in the last slide, there are many co-occurring medical conditions in individual autism. It doesn't mean that every individual autism has all these issues, but usually they have some of these issues, such as seizures, sleep disorders, they don't sleep, they're allergic to different things like food and so on, and gastrointestinal issues. And these are really very challenging for individuals and family living with autism. And for the average medical doctors, it's difficult too because of communication and sometimes physiological issues with individual autism. It's difficult for a physician to assess the situation as they would do with normal developing patients. But what is important is that if you can address these co-occurring medical conditions, you really will enhance the quality of life in general. Oftentimes you hear parents say that, gee, if my child, my son, my daughter can sleep through the night, for instance, and not stay up all night, it would be so much better. And this is the kind of challenge we're talking about here. But I think most of the time, what is really useful, what we know that has a lot of evidentiary support is behavioral intervention. And these typically are ABA, Applied Behavior Analysis-based intervention. They come in different flavors, different brands, if you will. And they could be, plain ABA, PRT, Jasper, ESDM, and so on. The important thing is that, there's adherence to each of these protocols, and there are families and therapists who claim that, their intervention is the best. But what we do know is that there's no one-size-fits-all solution, right? There's no one intervention that works with all the children with autism. And it's important to recognize that. And that, what we do know is that behavioral intervention, when it's applied appropriately and properly, it will alter trajectory of the disorder, it will prevent negative outcomes, enhance overdevelopmental outcome, and functioning, and such as communication, adaptive skills, IQ, and more recent research have shown that you can actually alter brain function with some of these behavioral interventions. And it's helpful throughout the lifetime, even though oftentimes you hear that earlier you treat, the better it is. What we do know is that every individual, it doesn't matter how old they are, can benefit from support and benefit from services. And that the key here is that the caregivers, right, whether it's family members or people in the community, their compliance to augment and to enhance or reinforce the intervention that's being delivered by a professional is really important for the success of this intervention. So we know that there are many challenges professionals and community workers in trying to support individuals and families with autism because there is a lack of practice guidelines in the community, especially in low resource settings. I mentioned in my last talk that we really don't know very much about how to best support individuals living with autism in low resource settings. All the intervention that's been developed today has been done in high-income countries. And we know that when we try to apply them in areas where you don't have somebody who has gone to school for 8 years and additional 4 years for BCBA, whatever, how do you make sure that these behavioral intervention best practices in high-income country can actually be effective in low-resource setting is actually a core research question these days. Again, also, there's no one-size-fits-all. So a therapist, a professional, really need to understand the principles of intervention, and that so if something doesn't work, you can try to find another strategy to support individuals and families. There's no consensus among experts on what is the best practice. In most disorders, diseases in medicine, is usually a standard of care that you can use. In autism, there isn't such a thing. And I think the last thing is really the major challenge, is the distrust of professionals. You heard the questions about vaccines in the plenary session. I think that's one of the indications of the profound distrust that many families feel for professionals. And that could come from a variety of sources. Diagnostic odyssey is something that we hear about all the time. Recently I was at a conference 2 weeks ago in Africa, actually. I heard a mother from Uganda who shared with us that she had to go see 9 different doctors before her son was diagnosed with autism. Every doctor had a different opinion. Boys speak later than girls. Nothing to worry about, he'll grow out of it, and so all kinds of reasons. Maybe just a hearing problem, that's a common thing. So the fact that they can't get an easy or straight answer from a professional just increases the stress that many families has for professionals. And in trust, as with regular medicine, is a critical component for a successful outcome for affected child. Because if you don't trust the service provider, the people that are providing the treatment intervention for your child, then it's difficult to comply with his or her recommendation and to do the best you can for your child. So we heard that for many families around the world, it doesn't matter if you're from high-income country or low-income country, they face similar challenges post-diagnosis. The health and well-being. For many parents, for example, there's a sense of anguish, there's guilt, and fear, and being stigmatized, feeling isolated. And there's reluctance sometimes, or inability to even share with family members. An example is that we did a focus group with a group of parents in Mexico. And the thing that keeps coming up is that every time they try to talk about this with their family, with their parents, for instance, it becomes a religious discussion. What does that mean? That means that the parents invariably say, what have we done to deserve this punishment from God, right? So it's not about the child and what we need to do, but it's because some divine intervention that led to the autism in this particular child. Of course, in these days of internet, you can have, anytime if you just Google autism, you get tons of information out there. But very few parents has the ability to discriminate of this information, to figure out what is evidence-based, what can be actually helpful, and what may be just confusing. So when I say there's tons of information but lack of real knowledge, that's what I mean. And because of that, dealing with a child with autism is extremely difficult and challenging. So for a parent, sometimes your confidence is shaken. Sometimes you feel like, maybe you can't do what is best for this child. So that's an important issue to address for the role of caregivers. So there's a paper that I published recently, and I'll tell you more about this soon, in New York Academy of Sciences. And it talks about the maternal psychosocial factor that influence care of a child. Now, this study was done about providing a nutrition program for a child. But the lessons learned here, and this is done in low resource setting in India and Pakistan. The lessons learned here, I think, is applicable to autism, developmental disability, not only in low resource setting, but also in high-income countries like the US and Western Europe. So on an individual level, we know that stress is obviously a very important factor, very common among women actually. Interpersonal conflict, for example, marriage discord, fighting with neighbors and so on, is a factor. Negative events in outcome, negative events in childhood. For example, some parents, because they experience poverty and loss of parents, influence their in the sense of self-esteem, the motivation to help, and of course, being irritable. Negative factors, behavior, such as abuse, neglect, and so on. On the family and community level, you have lack of family support that I mentioned earlier, but also sometimes at least in some societies, the parent feel like, or the mother often feel like they have to do everything. They still are expected to do everything, even when they have a child with autism. Sometimes the mother are not empowered to take action because of tradition and so on. So that even they're concerned, they want to do something, they have to get the support and the permission, if you will, of other family members before they can actually do something. So there's a sense of lack of control. And economic issues, there are poverty, competing priorities like work and so on that can influence ability of a mother to properly care for their child. And of course, limited education, traditional beliefs. In certain parts of Africa, for instance, you still hear about autism being caused by witchcraft or voodoo and so on. So how do you really help the parents to better understand what autism is and how to better support their children is a key challenge. So this is the paper, and it's available for free online. I encourage all of you to download it if you can. Just go to New York Academy of Sciences, you'll see it. It's a special nutrition supplement. So as you talk about integrating maternal social behavior, social well-being into child development intervention, it's called the 5 pillars approach. And what it does is it includes family support, empathic listening, guided discovery, behavioral activation, and problem solving. What it really fundamentally is saying is that for a professional, it's important to listen, to understand before you act. All right, so what does this mean? Family support usually means that the professional or the community health worker need to invest time to engage other family members. So in order for the mother not to feel too isolated, you want to making sure that they get the support of the father, and particularly sometimes the in-laws, as well as other extended family members. And the way you do this is by leveraging shared agenda, because parents want the best outcome for their children, right? That's a shared priority. Doesn't matter if you're the mother or the father or the in-law, grandparents, what have you. So you want to use that as a starting point and try to discuss how can we work together to enhance the best outcome of the child. And when you do that, you actually increase access to the whole family by professional services and so on. Empathic listening. This is actually probably one of the more important factors. There's a tendency, for example, in America, where the professionals will just tell the patient, you should do this, you should do that, okay? And this is, of course, based on their training, this is based on evidence, and so on. But what often happens is that when they are busy doing that, not really listening to the families, listening to the caregiver. And it's important to have skills of active listening. You want to show interest, you want to show empathy, and provide feedback so they get a sense that they're hearing you, that you're hearing them, that you understand their issue, to understand their challenges. In this way, you can develop a trusting, safe, therapeutic relationship with the mother and the whole family. Guided discovery. Sometimes there's differences of opinion within the family. Some are because of tradition, some because of different views about, for example, might be the best treatment, and so on. And that can be sometimes be contentious. And the way you resolve these issues is to use pictures of family member, use a representation of a family member. Instead of saying, you think this, or you thought of that, you said, well, in the family, we have this kind of belief or this kind of thoughts, and how can we talk about it? So you kind of put a little distance between you and the situation at hand, and that ease conversation and dialogue. And this is particularly helpful when literacy is an issue or education is an issue, and it's really a powerful tool for engagement and behavior change. Behavioral activation. So oftentimes, when we try to engage parents, say, okay, we're doing some behavioral intervention, like ABA-like intervention in a professional setting. When you go home, you need to do this and reinforce it to augment the lesson. Sometimes the parents say, too much, I can't handle this, right? Because they're already dealing with so many different things. A lot of times they're stressed already. They feel like you're just adding another thing onto their plate, and they just can't deal with it. And the way you manage this is really trying to break the task that is involved into small, manageable activities, right? Instead of saying, okay, you have to figure out how to do joint attention, okay? Maybe you can do smaller steps, things that are more understandable and manageable by the parents. And then you develop a schedule so they can practice and implement these baby steps. And over time, these things will add up, and they will actually become skilled at these activities. And then you want to have a calendar to record progress and problems that they encounter, which they can share with the professionals and so on. Problem solving. No lecturing. Don't lecture the families because it doesn't help. You need to engage them as partners, right? You need to engage them to solve the problem because every family is different. Every family situation is different. To assume that you always know the answer and how to address them is probably not the most helpful way to go about things. And so you want to sit down with them and identify, analyze problems together, and then try to figure out how do we solve these problems collaboratively. So they feel like they're supported, they can benefit from your professional expertise, but they have a role in this whole process as well. They can contribute. The knowledge of the family dynamics, the knowledge of the child can all play into how to really solve a particular problem. So all this is really saying is that I think the traditional way of medical care, where a more authoritative figure will dictate what needs to be done, need to be changed, right? So that you can accommodate the issues, the family dynamics, and individual factors that are at play. But when you're thinking about implementing intervention at a community level, let's say early screening, for example, in a community level, you also need to think in a similar way. And when I say that a lot of the solutions or best practices that have been generated in North America, Western Europe, the high-income countries, for instance, the reason they don't work in low-resource setting or are feasible, sustainable resource setting is because there's no community engagement, right? Just like you don't get the family to buy into intervention, or a family, or mother or father to buy into intervention for a child, is at the community level is the same issue. If the community is not really engaged and understand what you're trying to accomplish, it's very difficult to make a policy or program to be successful. They need to have some sense of ownership into this process. So the principle is that when you introduce a service into a community, the question you always have to ask is, what does this mean for individuals and families? Because you need to explain it to them, how would this benefit you, right? You may not understand it, but you can't assume that they do as well, or it's readily apparent to them. You want to make sure that it's inclusive community collaboration with service an honest broker. Sometimes there are different opinions within communities, right? Some parents may believe that gluten-free, casein-free diet is the best course for their children. Other times, parents may believe that lots of exercise may be helpful, and so other times maybe they believe that PRT is better than ESDM or Jasper. So you want to, as a professional, the role that you play is really one of honest broker. You want to try to identify common grounds for these activity and try to unite them with their shared interests rather than the differences. And then you want to offer tangible, immediate benefits, longer-term returns. You have to remember that parents in general, they want to see results. They want to see progress in their children soon. And if they don't see that, they start to lose confidence, they start to lose interest, and they move on to something else. So when you design a community-based intervention, you always have to think about what can we deliver to the families now, right? That's meaningful to them. But at the same time, you lay the foundation for longer-term return, longer-term benefit, system change, if you will. And of course, the most important thing that I keep emphasizing over and over again is that you have to listen to the parents, okay? You may know best about certain things, but you don't know everything. And oftentimes, parents will give you the best information so that you can do the best you can to help them. So this is an example of a program we introduced in New York community. And this actually came out of our support of the prevalence study in South Korea. And this is done by, it's called New York Korean Community Autism Project. This is because I live in Queens. I used to live in Queens. My neighbors are mostly Koreans and so on. And my son has a language delay. And when I tried to seek help for my son, our pediatrician was living in another county that was a little wealthier and so on. So when we first went to seek help, oh, it was great. You make a call and the appointment set up and you start to get the services. But when they found out that I actually don't live in the wealthier county, I live in the poorer county, they direct me to a different number. And it was a mess, right? Because you can't make heads and tails. The people involved changes, they give you different information. And I started to think that if I have this challenge with this information, imagine somebody who may be immigrant, who maybe recently moved to this country, who may not speak the language, who may not understand the system. How are they going to navigate this? And indeed, when we went to the community clinics, to ask them, how many families with autism are you serving? The answer is autism. We don't serve any family with autism. But then you go to the churches, in less than 24 hours, we're able to do 40 families with children with autism. So there's a significant disconnect between the services that are available already and families actually doing something about it and seeking behavior and seeking help. So the aim of this project is really to understand the cultural and structural barriers to early detection and access to care, and how do we implement community-based intervention by lowering age of diagnosis, increasing access to services, evaluate the services. What is notable is that the investigator, one is actually a cultural anthropologist, and the other one is a service researcher. So it's not just a service researcher or autism expert or intervention expert. We want to understand what are the cultural, the social factors that are involved in implementing and making sure that intervention works within the community. So the first thing we did is to understand the barriers. We actually conducted extensive literature review, some of them in Korean, to understand what is the Korean families or parents' expectation when they have, in terms of healthy child development. Because every culture had slightly different expectation in terms of what does it mean when you're successful parents. Sometimes academic achievement, sometimes is more happiness. I think all this involved, but there may be different priorities associated with different cultural standards. Then we had a community stakeholder meeting where we brought together caregiver, parents, clergy, pediatricians, social workers. We want to benefit from all the different perspectives, just like when we try to engage family members, understand the issues that are there. And then based on the information or the lessons that we learned from the community, we adapted the materials, the outreach materials for the community, such as the early warning signs, and the 100-day kit that Autism Speaks produced to support parents of newly diagnosed children. Then we implement and evaluate their performance. So we had this community advisory board of all the different professionals and as well as parents advising us. We asked them how is the best way to share this information within the community. For the Korean community, it happens that there's a really strong faith-based community among the Korean families. So going through churches, for example, has been a very positive way to do this, going to schools. And then we interviewed professionals. What do you know? What did you learn when we shared this additional information? And what did you do? How did it help change your help-seeking behavior? So we asked all the stakeholders, parents and professionals alike, about the materials we want to introduce and how they may change their perspective on things. What we learned is that the essential activities for successful community intervention is that you want to engage community, so there's inclusive collaboration, a multi-pronged dissemination strategy via key stakeholders. You want to collect data and continue to refine the process, and you want to make sure the sustainability. So what that means is that in our case, is that we actually started to train social workers that are embedded in the community to start to deliver some intervention. I'm happy to say that recently, a couple weeks ago, as a matter of fact, a hotline was launched in the Korean community, manned by the social worker service that's trusted in the community, that has a good history, good track record in the community, and they're now providing this information for concerned parents and so on. You may say that this is a lot of work just to launch a hotline, but I think this gives some sense that this is really the right way to do things. And because the community has been along for the ride every step of the way, they bought into it. They feel that this is part of what they're offering, what they have available in the community. This is what they're offering to the families. So they're helping us to spread the word to families. And I can tell you we're getting a tremendous amount of traffic in this hotline right now. So that's it. So that's sort of the basic principle I want to share with you.
Thank you very much, Dr. Andy Shih, for addressing this interesting subject on service provision. We now open the floor for questions.
Yeah, afternoon, Dr. Andy. Perhaps I'm a parent. My name is Cheng Hui. I'm a parent of an autistic boy, 27 years old now. Perhaps maybe doctor can share with us, because most parents fear that they are not able to actually help their child. So where can we get resources? Because again, sometimes the resources can be very expensive. So would there be any way where you can help us by giving us, say maybe, the resources where we can turn to? Thank you.
Thank you for that question. It's really a great question. We hear that a lot as we travel the world and talk to different families, and you know that seems to be a common challenge for all of it. And I guess the easy answer I can offer to you is that Autism Speaks. You go to Autism Speak website. If you look under the homepage, under the banner, there's a link to called Toolkits. If you click on the Toolkits, you'll see a list of toolkits that we have produced, often with professionals such as American Academy of Pediatrics and other experts. And all these toolkits are free, okay? And there can be things as complicated as transition. You know, you're going from going to adolescence, you're going to adulthood, how to really manage that process. And as seemingly simple tasks as getting a haircut or going to the dentist. So these are all toolkits that we have available for families everywhere. You can download for free. But I want to caution you though, and this what I'm saying is an easy fix, but maybe not the best solution for you, is that these toolkits were developed from the perspective of a largely white, middle-class American family, okay? So things may be different in Malaysia and our parts of the world. Certain things may be true and may carry over to different society communities. But once you have that information, you need to work with other stakeholders, other families, and try to decide what is relevant for you and your situation, and maybe accentuate that, maybe add different things to it. And when things are not relevant, you want to maybe minimize it or eliminate it. And the only thing we ask is that before you do that, contact us. You can contact me, actually, and my team help manage this. Contact me, tell me what you want to do. And the reason for this is that we like to collect all the modification that's being done so that we can share with other families who are interested in doing the same thing that can benefit from your experience. Right. So again, there's a simple answer and a more complicated answer. The simple answer is that you share with them knowledge that's been accumulated elsewhere. So for example, the CDC in the US and for disease control US has a simple thing called Learn to Sign Act Early. So what it means is that they list early warning signs of risk for autism by age, right? So, for example, by age of 12 months, they should be able to respond to their name. And at another age, they may be able to have some social smiling and so on. So that's one way you can educate the parents and help them become more aware. And I think that speaks to the importance of general awareness in the community. That's why the work of Simon Hussein and the Bangladesh government is so important in helping the community understand what are the potential risk warning signs for autism. But again, that is you're basically importing a solution into your community, and that certain things may not be appropriate and certain things may not work as well in the Bangladeshi culture. I don't know what they are, right? But the idea is that you understand the concept of using early warning sign, of the concept of what will elicit in Bangladeshi parents concerns about their children's development. Like you said, when they're just playing by themselves, they're not playing anybody else. Many parents, maybe do not pay attention to that. And that's not just unique to Bangladesh, of course, other society as well. Maybe the challenge there is to think about what can you do, what can you and other stakeholders do that will raise an issue with your average Bangladeshi parent about their child development. So the concept is same as CDC, Learn to Sign Act Early, but you want to contextualize it so it's appropriate for the Bangladeshi community. And that's a lengthier process. Again, that's something that Autism Speaks can be supportive of. It's part of our global public health initiative. So.
Talent or academic, his academic years or his social skills? Which one is more crucial for autistic individuals?
Right. So it's a great question, right? And again, I think every child is different, and you know your child best in terms of what may be most helpful. What I can tell you that in general, challenging behavior in children with autism is typically due to frustration because inability to communicate, inability to let the caretaker or others in society know their needs and their wants. So in that sense, being able to facilitate social communication is probably more important. And we also know that if you can manage these challenging behaviors, that it actually enhances the ability of a child to learn and make progress. So in generally speaking, again, you know your child best, but generally speaking, I think that if you focus on social communication rather than academic, it's probably better for the child. Another example I can give you is that, Dr. Kim talked about the high prevalence in Korea, and she talked about how if you look in special schools, you see about 1%. But when you go to mainstream schools, you see 1.6%. And these are children that have not been previously identified. What that means is that because I grew up in Taiwan, so I'm been part of that the education system, and that I know that in some Asian culture, they prize academic achievement above everything else, right? So as long as you do well in school, you behave, you don't have any overt issues, then you're fine. And nobody bothers you, you're a great student. But that doesn't address your fundamental social communication challenges. As a matter of fact, I recently, actually about 2 years ago, I visited Tokyo University in Japan. They instituted an adult diagnosis program. It's because Japan, like Korea, has very structured school system, okay? And so that if a child with autism, let's say on the milder end of the spectrum, if they perform well in school, there's no issue, right? They're not identified, there's no service support and so on. But when they go to college, where the environment is much looser and where there's a greater demand for social interaction, that's when they begin to suffer. As a matter of fact, if you look at the pilot program that was implemented at Tokyo University, of the 50 or so individuals that first diagnosed, every one of them was diagnosed with other psychiatric condition, depression, manic, mania, and schizophrenia in some cases. And then all of them eventually were diagnosed with autism. It's because once they get into that environment, they don't know how to function in the expected way, and they start to suffer. So I think that underscores the importance of building that social communication skills, ability, in order for them to be able to adapt to different environments better and be able to communicate better and be able to engage better. And that will ultimately help with the, I think, academic achievement as well.
Hi, good evening, Andy. My name is Ram, and I got two kids, which is one is 5 years old and the other one is 3 years old. Now, my second child, 2 years old, is suspected to have autism, right? And I'm going to engage with a doctor to diagnose and to see at what level. But what we see is a mild autism. Now, my question is, when we approach a doctor when the child gets diagnosed, typically how long or how many times the child need to go through a diagnostic for it to be confirmed a mild autism or what? Sorry if it's a stupid question or what, because this is very new to me. Number two, do you think in your experience, I need to have second opinion, third opinion, and fourth opinion to see a few doctors just to make sure that the child is in the right program? And then the other question I have, my daughter who is 5 years old, there's no symptoms of autistic or what, but do you recommend any kids below 6 years old to go through a program just to make sure that the child is free for any autism or any other diseases? Right. Thank you.
Okay. So just to answer the first question, I think diagnosis is behavioral diagnosis is oftentimes more of an art than a science per se. And if you look at the gold standards in autism diagnosis, the ADI-ADOS, that's really largely based on clinical experience, right? So what I would say is that if the clinician that you're seeing has a lot of experience diagnosing children with autism, you probably would trust that individual's perspective more readily than somebody who had maybe seen one child who had maybe never seen a child with autism, but I've read about it in the book or has seen the diagnostic criteria. That clinical impression, the clinical judgment is oftentimes the best indication in terms of making the diagnosis. But having said that, we also know that children behave differently in different environments sometimes, right? We all have experience, certainly I was that, when I'm in a large crowd, when I was a child, large crowd with a bunch of strangers, I tend to clam up. I tend to just focus on my own things and not pay attention to everybody else. And so you've only used that situation as an indication whether the child has autism or not, or autistic-like behavior or not, may not be the most accurate way to go. So typically, you hear, I think Dr. Kim mentioned this in her answer to one of the questions in the end, you want to do this in different settings. You want to have different informants in different settings. The teacher, different parents, maybe the grandparents, they share a similar concern with you. And then when you do the assessment, sometimes you want to do a couple of visits instead of just once. But having said all that, that's not always necessary. I think the milder end of the spectrum is more difficult, more challenging sometimes to make that determination. But I think it's been estimated about 85% of the autism, the presentation is pretty obvious, and that a fairly experienced clinician should be able to tell, pretty readily. So, and then I think the second question is that whether or not your younger child?
My elder child, 5 years old.
5 years old daughter.
The one?
5
Yeah.
years old daughter. He's
Okay.
Maya.
So, if you have an older child with autism, the chances of a younger child with autism is about 20%. Okay, so that's significant. And the recommendation there is always that if you have one child with autism, you have a younger sibling, you want to probably be more attentive to his or her development, and have maybe more regular checkup, or consult professional on a more regular basis. But having said that, I think there's a discussion in public health at this point about whether or not it's beneficial to do universal screening of children, right? You can see pros and cons in that, because when you screen, because especially before age 3, oftentimes diagnostic autism presentation is not stable, and that we've seen cases where at age 1.5 or age 2, the clinician's concerned, but then by age 3, much less concern. We also seen cases where there's no concern at age 1 or 2, but then end up child being on the spectrum. So it tend to vary. Now, so I think parents being aware of the warning sign is probably the most important thing in terms of then to encourage universal screening, because sometimes that just introduce unnecessary concern and anguish within the family.
Maybe. Okay.
We also find the same difficulty diagnosing autism when very young, because we are always telling that earliest to diagnose earliest and start therapy earliest, but all the tools that we use like DSM-4 and even in Isha, which is used in India, these are very difficult to use when under 3 years. So in our country also, we have observed that most of the parents, they are taking their child even at 1 year or most by 18 months. So it becomes very, if it is less than 18 months, even less than 15 months, it is also difficult to do the MCHAT. So only by knowing the danger signs or parental anxiety can we, the doctors, say that it may be autistic. Because if the parents heard that their child may be autistic and we refer, just go to a teacher and they take the intervention, this is very devastating. Sometimes even they discontinue their jobs, and even the family breakage, even that can be done. And after a few years, like 4 years, 5 years, when we diagnose that yes, it's autism is there, or autism is not there, it's not the cause, and then they blame the doctors, that doctor told our child is autistic and is a very bad doctor and whatnot. So what to do? Should we tell that maybe autistic, just doing the MCHAT, that is a checklist only, not diagnostic? So what should we do?
So again, I think that speaks
Thank
to I think that uncertainty, I think, speaks to the importance of really enhancing overall community awareness of autism, the warning sign, because I think Dr. Kim and other speakers have mentioned this, is that at the end of the day, parents know their children best, right? Especially if you had a child already, and if you look at the peers of your child, and you can see whether or not your child is behaving in a similar way or not, and whether you should be concerned or not. So I think parents usually, there's a saying in the medical research community that parents are usually, when the parents concerned about a child having autism, they're usually right about 85% of the time. Okay, the 15% is the ones that are a little more difficult to tell. You might want to have professional input and so on. But if you have a basic understanding what the early warning signs may be, that's going to be your best tool, I think.
Thank you. I'm sorry, but I think that's the only time we have. But maybe we can have one more question from this lady in front here. She's been waiting. Is it all right, Dr. Andy?
Sure.
Okay.
Fine, yeah.
I'm Dr. Papa Siddhi. I'm a consultant psychiatrist from Sri Lanka. In my facility, I'm based in Kandy, central part of Sri Lanka. I know you're working closely with my pediatric colleague, Dr. Samantha,
Yeah.
but I'm in the middle of the country
Yeah.
center. And my main problem at my teaching hospital, Canadian University, is the care exhaustion. Because we don't have the infrastructure. I only have my junior doctors, postgraduate trainees, and the medical students, about 15 in a little room.
Yeah.
There are stairs, no speech therapy. So at the meantime, I came across those planning and actually planning a center, at least a day center to start with, and then moving on to a rehab center, at least at a small scale, struggling. So my humble request from you, Dr. Andy, is it all right if I write to you, email, in need of any guidance when we're stuck in the process, when we are moving ahead with the local officials?
Oh, of course. I think, our interest is to serve the stakeholders in the Awesome community worldwide. So you have a particular issue and question, feel free to write me, right, and ask those questions. I may not have the answers, and I will tell you if I don't have the answer, but I can recommend usually a process in which you can find the answer or discover the answer.
Thank you so much.
Okay, thank you everyone for the questions and feedbacks. I'm sure we have a lot of questions for Dr. Andy Shih, but maybe we can have ask him during the tea break. And on behalf of the organizing committee, I would like to thank Dr. Andy Shih for sharing with us this wonderful topic. Thank you.